Welcome and thank you. Our bi-weekly webinar series has been going on now since April of 2020, and we do this to highlight research at the University of Pittsburgh School of Medicine in the two world-renowned departments of ophthalmology and otolaryngology, head and neck cancer at the University of Pittsburgh and UPMC. So today we're going to be talking about cochlear implants, and I'm going to introduce our speakers here today in just a minute, but some housekeeping rules real quickly. This is a webinar series. We disable chat, so it's not like a Zoom call where you can chat your friends. Chat will be disabled. Q&A functions can be open for you to be able to answer questions. Please refrain from putting the personal questions that you might want to have about your own current health situations into the Q&A, but you can send those at any time to Mr. Craig Smith. He's the email invitation on your webinar link that you received. And then, if you need to, please use the subtitle function in closed captioning that we make available for you. And then, of course, we'll be putting you on our invitations for future webinars, and we do these every other week, as I mentioned. I actually think we have one next week because we're a little out of rotation, so we have another one next week that you may be interested in as well. Let me introduce our wonderful speakers. We're going to have Phil Perez, Dr. Phil Perez. He'll be going second, however. Assistant Professor, Department of Otolaryngology and Head and Neck Surgery. Dr. Perez specializes in otology and neurotology and is board certified in neurotology by the American Board of Otolaryngology. He treats full range of otologic and neurotologic disorders with clinical focus on cochlear implants and treatment of vestibular schwannoma. Geez, Phil, you have to tell me what that is. He's son of a Mexican immigrant. He's also interested in health disparities, minority population expanding, UPMC's outreach to underserved communities through work with the Birmingham Free Clinic Mission of Mercy. He serves on the board of Pittsburgh Center for Hearing Deaf Services and co-medical director of Western Pennsylvania Lions Hearing Foundation. Thank you, Dr. Perez. And then we have our first speaker is going to be Jillian Glasstetter, who is the coordinator of Cochlear Implant Programs for Audiology. She's an audiologist at the Department of Otolaryngology. Jillian's an AUD, is coordinator of the Cochlear Implant Program at UPMC. She received her doctorate degree in audiology from The Ohio State University after receiving her bachelor's degree in cognitive science from the University of Delaware. Prior to working at UPMC, she completed her audiology residency at the University of North Carolina, Chapel Hill, specializing in adult cochlear implant care. Her interests include adult cochlear implant assessment and programming, diagnostics, hearing aids, and clinical education. She's also a lab instructor at the University of Pittsburgh and teaches the Implantable Devices lab each summer. Thank you. So now we're going to hear about expanding access to cochlear implantation. Who is a candidate now? Please take it away, Jillian.
All right. Hi, everyone. Thank you for spending your lunch with us. I love talking about cochlear implants, so I am excited to share some of that with you all today. I want to first make sure we have a basic understanding of how we hear. So sound is going to come in from the outside world, going to travel down the ear canal. It's going to vibrate that middle ear portion, which is our eardrum, and those three middle ear bones, the hammer, anvil, and the stirrup, if you remember from health class. Those vibrations will then vibrate the fluid inside of our cochlea, which will then stimulate the hair cells and stimulate the auditory nerve. So that is how we hear naturally on a day-to-day basis. When we hear with a hearing aid, we actually use the same mechanisms. The difference is just that we are picking up sound using the microphones of the hearing aid. So the sound comes into the microphones of the hearing aid, it is amplified, and then it still travels down that same mechanism, down the ear canal, vibrates the eardrum, the three middle ear bones, the fluid in the cochlea, and up to the auditory nerve via the hair cells. For some people, this is sufficient, right? So for some people, amplification or turning the volume up is enough to overcome the hearing loss. But for a lot of people, it's not. So what's happening is the sound with a hearing aid is still being pumped through a very damaged system. So essentially, there are just not enough functioning hair cells to get a clear signal from the outside world up to the brain. So there may be enough hair cells to hear beeping sounds, so you may be able to hear something, but you can't quite understand it. So what we do is we bypass all of that. So we are actually going to bypass the outer ear. We bypass the middle ear. And we actually are bypassing the cochlea and the damaged system itself. We're using the cochlea to house the device, but we're really bypassing it and stimulating the auditory nerve directly. So I am going to play a quick video that will show us how a cochlear implant works.
A cochlear implant turns sound into electrical signals that your brain can understand. Sound enters a microphone in the speech processor, which converts it into a digital signal. This signal reaches the transmitter, worn on the head, which sends it wirelessly through the scalp. The receiver, implanted in the skull, turns it into an electrical signal and sends it to the cochlea. Electrodes in the cochlea stimulate the auditory nerve, allowing the brain to interpret the signals as sound.
So that is how we hear with a cochlear implant. So like I said, we're bypassing the damaged system and we're stimulating the auditory nerve directly with electrical stimulation. So now that we know how a cochlear implant works and how it's different from a hearing aid, I want to just do a bit of a brief overview on sort of how far we've come and how we got to where we are today. So we first started implanting people with cochlear implants around the 80s, and the criteria were pretty strict then. It was, very profound hearing loss and really no speech recognition. So kind of what you think of when you think of somebody who maybe was born without hearing. And then in the 90s, that expanded to include people with a little less severe hearing loss, so more so in the severe range. And we started to shift towards looking at the benefit from hearing aids, or really lack thereof. And then in the 2000s, we broadened that even further, and we started to implant people with moderate hearing loss, and the focus really became on speech understanding. So less so on the audiogram and, how loud do the beeps have to be before you say yes, and more so to, are you gaining benefit from wearing hearing aids? And if not, maybe we should talk about an implant. Today, we are going to focus primarily on what has happened from 2010-ish up until now. So we'll get into each of these in just a minute, but that is sort of how we got to that point. I always like to remind everybody of this statistic, which is pretty jarring, and it's very interesting. So fewer than 10% of people who qualify for a cochlear implant actually receive one. This is because a lot of people may not know that they qualify for a cochlear implant, or that their parents or their loved ones qualify for a cochlear implant. And that is due in part to, the historic candidacy criteria of having to have that profound or severe to profound hearing loss. This drives a lot of the work that we do in our clinic, which is to get the word out and let people know that they may qualify for an implant and they may benefit from a cochlear implant. I'm going to be showing a handful of examples of audiograms or hearing tests. So I just want to orient everyone. This is how we graph our hearing. So up at the top, we have frequency or pitch. So over on the left, we have very low, deep pitches. All the way on the right, we have very high frequencies or high pitches. And then on our y-axis, we have volume. So up at the top of the graph are very soft sounds. And as we go down on the graph, the sounds get louder. So you can see some kind of common sounds that are plotted, leaves rustling, whispering, birds chirping. Those are all very soft sounds. You have your speech sounds, which sort of fall in that sort of 20 to 50 dB range. And then as we go down on the graph, you see your vacuum, your dog's barking, the baby's crying. And at the very bottom, the shooting of the guns, the jet engines, that sort of thing. I would also argue my dogs are down at the bottom of the audiogram as well when they bark. So this is how we graph our hearing. So essentially, the further down on the graph we go, the louder we had to make beeps before you said, yeah, I can hear that. So here are some examples of what we have historically considered cochlear implant candidates. So as you can see, all of those symbols, so the blue is the left ear and the red is the right ear, all of those symbols are falling within the severe to profound hearing loss range. So these are real people who have cochlear implants. And like I said, sort of in the 80s to 90s, even up until the early 2000s, this is what we would consider somebody to be somebody who could receive a cochlear implant. Both ears are falling within that range. And we've come a long way since then, but this is sort of what we would expect historically for our candidates. So one of the ways that we have aimed to get the word out about cochlear implants is through something called the 60-60 rule, which we're going to dissect a little bit. This rule came out in 2020 after some data from Michigan Medicine, and it is really just a quick and easy way for providers to know if and when a patient should be referred for a cochlear implant evaluation. So the key word there is referred. So this does not mean that they are going to be a candidate. It does not mean that they would qualify for a cochlear implant. It just means that it's worth looking into and worth investigating. The two criteria are both 60, which is why it's so easy to remember. Criteria number one is a pure tone average. So we'll talk about what that is. A pure tone average of 60 dB or worse in the better ear. And the second criteria is a speech understanding score of 60% or worse in the better ear. And we will talk a little bit about how to find out if someone you know or if you yourself meet that 60-60 criteria. So our first criteria is that pure tone average. So it is an average. So we are adding up the detection level or the threshold value at 500, 1000, and 2000 hertz. So for example, the left ear, our detection level thresholds in the left are 70, 60, and 50. So if we add those up, divide it by 3, we're going to get 60 as our pure tone average. It is usually listed on the audiogram somewhere, so you can usually tell, what that is without having to do the math. But if you wanted to calculate it yourself, that is how you would do it. The other thing we're looking at is that speech recognition score. So this person in the right ear has a score of 4% in the right ear, and in the left ear, they have a score of 30%. So this person happens to meet both 60-60 criteria, both the pure tone average having to be 60 dB or worse, and the speech understanding score having to be worse than 60 dB, 60% rather. But you do not have to meet both. You can meet one. And that is plenty. That is sufficient for a referral that you may consider undergoing an official cochlear implant evaluation. Just for what it's worth, I wanted to show you all this person's outcomes with a cochlear implant. So she came in and her right ear was the ear that we implanted. And as you can see, she was really not hearing very much, or really, I should say, not understanding very much. So 0% on most of those tests, certainly under 20% on most. She did go on to get a cochlear implant in that right ear, like I said, and those little CI right symbols are all falling in that normal hearing to mild hearing loss range. And her scores, as you can see in the bottom right there, are pretty good. So she went up quite a bit in her speech understanding. Now, obviously, this is one example. Not everybody is going to do this well. She is a very good performer with her implant, but it is just an example of what somebody with an implant is capable of. Some other things to consider when you're thinking about, would I benefit from a cochlear implant, is if your hearing aids are no longer helping you understand speech. So maybe you've tried hearing aids for years and years and they're just not cutting it anymore. So even with appropriately fit hearing aids, they're functioning, they've been verified using, evidence-based practice, and you're still not able to understand speech, maybe we consider talking about an implant. If you struggle to communicate over the phone, that's going to tell us that you're relying pretty heavily on visual cues or seeing somebody's mouth. Obviously, we can't do that over the phone. Or if you're finding yourself withdrawing from social events. So, it's just easier to say, I'll just stay home. I can't hear anybody anyway, right? That's a sign that maybe we need to talk about the next steps beyond hearing aids. And again, you're always asking people to repeat themselves. So if you're somebody who might say everybody mumbles or they're just not loud enough, and again, all of these are with hearing aids. So if you've tried hearing aids and all of these things are still true for you, that's when we may talk about a cochlear implant. So we've talked about our 60-60 rule. And like I said, that is one way for us to just kind of bring people in so that they are aware of the fact that they may benefit from a cochlear implant, or maybe if they don't, today, maybe 2 or 3 years from now, that time will come. So we've talked about our 60-60 rule. We're going to talk about another way we have expanded criteria in the last 10 or so years, and that is via what's called electroacoustic stimulation. So we'll talk a little bit more about what that means. But here are some examples of audiograms of people who we have implanted and used that EAS, or electroacoustic stimulation. So historically, we would have looked at these hearing tests and said, honestly, you have too much hearing to lose in those low frequencies, right? Some of those detection levels fall even within the normal hearing range. So we might say it's too risky, you hear a lot with your hearing aids. It would be a lot to take away from you if that were to drop. But really today, it has become the standard of care to implant people who have hearing loss like this and accompanying word recognition difficulties. So, if somebody comes to us and their speech understanding is fantastic with a hearing test like this, we're not going to mention a cochlear implant. But if the speech understanding is poor, then it's absolutely reasonable to talk about a cochlear implant. Just because somebody can hear those low frequencies doesn't mean they are able to understand speech. Really, there's just so much damage in those higher frequencies, as you can tell as that audiogram slopes down, that the speech is just not clear. It's not a meaningful signal being sent to the brain. So how do we do it? How do we take advantage of natural hearing? It's pretty cool, actually. So for losses such as these, the surgeon is always going to make their best attempt to preserve hearing. It is very common these days that we can preserve hearing. It does not always happen, but it is always the goal. Okay, so surgical techniques have come a long way. The internal devices that are implanted are a lot softer, more flexible, and they cause a lot less trauma than they used to. So there are a lot of ways that the surgeon can approach the procedure to preserve the hearing, and Dr. Perez is going to talk a little bit more about that. But my job as an audiologist is to see what's left after surgery, and hopefully that is a lot. And so what we do is we use whatever is left to turn your hearing device into half hearing aid, half cochlear implant. So there's going to be one portion that still goes into the ear, and we're still utilizing the acoustic hearing or the natural hearing. And then we stimulate the other part with electrical hearing, or with the cochlear implant itself. And that allows for a lot of improvements in sound quality. It can help speech understanding in background noise, and it can really just help preserve the sound quality, the natural sound quality of hearing, to really be able to rely on some of that acoustic hearing. The piece that goes in the ear can vary. It just depends on what manufacturer you select. So it can come in the form of a wire and a dome, or it can be a tube into an ear mold. It's just totally dependent on the device that is selected and the manufacturer. One thing I will also say is that you may hear this referred to as a hybrid cochlear implant. That's fine. It means the same thing, but we are sort of moving away from that terminology and focusing more on calling it electroacoustic stimulation, or EAS. And the reason for that is because hybrid cochlear implant refers to a very specific type of internal device that is just not used all that often anymore, largely due to the fact that the surgical techniques have come so far that we don't have to use that specific internal device. So the preferred terminology today is the electroacoustic stimulation, meaning we're stimulating part of the device electrically and part of the device acoustically. And the last way that I will talk about today that we have broadened our indications is by implanting people who have hearing loss on one side and normal or near normal hearing in the other ear. So if we think back to our historic candidacy criteria, we would have looked at these hearing tests and said, you know, your hearing is too good in one of your ears and you therefore can't get a cochlear implant. But around 2019, a study came out that got the FDA on board with the benefits of binaural hearing. So they really started to recognize that we do need two ears to hear in a lot of situations. And there are a lot of benefits to implanting an ear, even though that person may have normal or near normal hearing in the other ear. Historically, the options to manage hearing loss like this, where there's, you know, severe or profound hearing loss in one ear and normal or near normal hearing in the other ear, there have been three common solutions. Option one is just a standard hearing aid, which again, as we talked about at the beginning, may make it louder, but it may not necessarily make it clearer. So another couple of options would be to take the sound from the good ear and take the sound from the bad ear and send it to the good ear. And that is done in a couple of different ways. We can do it via bone conduction. So we can take the sound from one side and send it to the better cochlea. That can be surgical or non-surgical. Or what's called a cross or a bicross. And that cross stands for contralateral routing of signal, which is what it sounds like, where it takes the sound from the bad side and sends it to the good side. However, those two solutions are still only allowing us to hear out of one ear. It's really not restoring hearing to both ears. So let's talk about why that's important. The importance of two ears is something that has really been a hot topic in the field of cochlear implants over the last 5 or so years. And really what made that study so successful was kind of outlining all of these benefits. So here are a lot of things that we do need two ears to be able to do. People who do not have binaural hearing or people who only have hearing in one ear are not able to tell where a sound is coming from, right? So sound is going to be louder on one side slightly, and it's going to arrive sooner to one ear than it is the other. And that's ultimately how we tell where sounds are coming from. And if we only have one ear, everything is just going to sound like it's coming to that side. So your sound localization abilities are just not going to be there if you only have hearing in one ear. We also need two ears to hear in background noise or those complex listening environments, those reverberant environments, background noise, you know, far away. We need two ears for that, just like we need two eyes for things like depth perception or things like peripheral vision. Also, a cochlear implant or hearing with two ears can help improve sound quality. So think of it as hearing sort of in stereo or surround sound rather than hearing in mono. So just an overall improved sound quality. A big one for people is the bothersome tinnitus or ringing in the ears. So a lot of my patients who have that profound or severe to profound loss on one side, they are also bothered by their tinnitus. So that ringing is a very common symptom that comes with hearing loss. And the data do suggest that a cochlear implant can help reduce the severity of that tinnitus, at least while wearing the device itself. And all of these things, to not be able to do those is going to increase your fatigue, right? So if you have to work harder to tell where a sound is coming from, you have to work harder to hear in background noise, you're going to be more tired at the end of the day. So a cochlear implant is really the only way to restore that binaural hearing and therefore the benefits of binaural hearing. So that is sort of what that study came out and said, you know, hey, this is really important and we should be implanting people even if they have hearing in one ear. So what are the criteria for single-sided deafness? The criteria are profound sensory neural hearing loss in the ear to be implanted. Now, what they do not specify with this criteria is how many frequencies have to fall into the profound sensory neural hearing loss range. So it could be a couple, it could be all of them, it could be one. If we go back to this example here, all the way on the right, you know, she has normal hearing at a couple of those frequencies, and then it dips down to a severe to profound hearing loss. So because she has hearing that falls in the profound range, she was a candidate for a cochlear implant. The better ear has to have thresholds that fall between 0 and 55 dB, so that's about a moderate hearing loss. If your thresholds fall outside of that 55 dB, that doesn't mean you can't get an implant. It just means you're probably going to be closer to a traditional candidate that we talked about earlier than you would be a single-sided deafness candidate. And the last criteria is, and really the one that we use most commonly, is the speech understanding score. So again, remember, our focus is on the speech understanding score, not can you hear it, but can you understand it? And that criteria that the study suggested was 5%, and that is very strict. And I will say that that is something that I anticipate is going to continue to change and to broaden in the next few years. Really, it already has. So technically the criteria is still 5%, but many insurances are implanting people, you know, up to 50 or 60%. It's 5% is really one word correct on a list of 50 words. And the reality is that people who can understand a higher percentage of words would still benefit from a cochlear implant. You know, if it's 6%, they're still going to benefit from an implant, or even, like I said, up to 40 or 60. So it's technically considered what we call off-label because the FDA released that recommendation of 5%, but I do think it's going to become standard of care in the near future to be implanting people with higher scores than that. Oops. One thing I want to make clear is that unfortunately, Medicare does not yet cover cochlear implantation for single-sided deafness. I think it's coming. I hope it's coming. They tend to be a little bit late to the game when it comes to getting on board with these new developments. Some forms of Medicare will pay for a cochlear implant. So for example, we work with a lot of UPMC for life patients, and that is a form of Medicare, and that they will cover a cochlear implant for single-sided deafness up to 60% speech understanding, actually. But if you have, you know, standard red, white, and blue, Part A and B Medicare, they're not going to cover it. We can't even submit for it. They've made it very clear that they will not cover it. So I just want to put that little caveat out there. So who is a candidate? What makes somebody a candidate? Just to recap. Historically, if you remember, we were implanting people with profound hearing loss only. And then in the 80s and the 90s, we started to go towards severe hearing loss and eventually the moderate hearing loss range. And today, we're covering a lot of the audiogram. So today, people who have some normal hearing thresholds are receiving cochlear implants. That does not mean that we're going to put cochlear implants in people who do not need them or would not benefit from them or who have normal hearing. But what it does mean is that if you are struggling and you have hearing loss and you have tried hearing aids, it may be worth looking into whether or not a cochlear implant would be beneficial for you. With our electroacoustic stimulation, we can account for those very steeply sloping losses, and we can take advantage of the hearing that you do have. So the criteria have brought in quite significantly to, like I said, cover a large portion of the audiogram. So for traditional candidacy, just to sort of make it black and white here, the criteria are a moderate to profound sensory neural hearing loss. And again, that's any threshold, does not specify. So as long as some of your thresholds fall in that moderate to profound sensory neural hearing loss range, you're going to meet that criteria point. And the second criteria is a score of 60% or worse on sentence understanding with hearing aids. So Dr. Perez will talk a little bit more about what this process entails, but we have you come in, we do a lot of testing to see what the hearing aids are doing or not doing for you. And essentially your score has to be 60% or worse on the sentence test while wearing those devices in order for us to say, yes, a cochlear implant would probably benefit you. For our single-sided deafness candidates, our criteria in the poorer ear are at least one threshold at 90 dB or worse, so that profound hearing loss range. And the better ear, the thresholds are going to fall between 0 and 55 dB. And again, that 5% score that I mentioned that I'm really hoping is going to increase in the near future. And like I said, some insurances are implanting up to 60%. So don't let that 5% number deter you if you or someone you know has a hearing loss that looks like this and normal hearing in the other ear. It's still worth a conversation. I do want to touch on just a couple other considerations. So the amount of time that you've had hearing loss and whether or not you've worn hearing aids is huge. That is the biggest indicator of success. So somebody who lost their hearing 6 months ago, their nerve is still, used to functioning versus somebody who lost their hearing 70 years ago. Those are two very different people, and that auditory nerve is certainly not going to function as well as somebody who, was hearing up until 6 months ago. Your cognition, we want you to understand what you're going through and make sure that you have an understanding of what this is. Family support, that's a huge one. So if you show up to your appointment alone, it's, how are we going to get through this? Who's going to pick you up from surgery? That sort of thing. We need to know that you've got support in this. And your motivation. So if you're here because you want to be here versus you're here because somebody else wants you to be here, those are very different things. So motivation is a big predictor of success. If you want to hear, you're going to do the practice and you're going to do the auditory training, the rehabilitation that is required. It's not a quick fix. So it's a lot of work. It takes a lot of time. So if you're motivated, you're more likely to do better from that perspective. Your overall health is important. So basically, are you able to safely undergo general anesthesia? And again, Dr. Perez will talk a little bit more about that. And do you have appropriate expectations? So it's not a quick fix. Like I said, you're not gonna wake up with normal hearing. It's never gonna sound as you remember, but the goal is for it to be better than how you're hearing right now or not hearing. And that's with or without a hearing aid. I also get this question a lot, which is, am I too old to get a cochlear implant? And the answer is probably not. So this data is from, a few years ago. Our average patient, their age was 63, and again, that's an average. We have implanted probably more than this at this point, at least 26 recipients at 80 plus, so 80 years or older. And we've recently implanted a 97-year-old, and I am turning his device on next week. So really what matters is, are you healthy enough to undergo anesthesia? I've seen some really healthy 97-year-olds. I've seen some really unhealthy 60-year-olds. So that is a conversation for you to have with your surgical team and your PCP. But you should not let your age be your deciding factor. Back to our timeline to wrap up here for my portion. What's next? So 2025 and beyond, my hope is that Medicare will expand to cover single-sided deafness, cochlear implantation. And we actually have also started to see them paying for a second cochlear implant. So again, the benefits of two ears, right? So there are a lot of data coming out about, the reasons why we need two ears to hear. So there are a lot of people out there who have one cochlear implant and one hearing aid and who are still struggling, and that hearing aid is maybe not doing a whole lot for them, and they would benefit from a second implant. So we are seeing insurances and particularly Medicare start to cover a second implant. I will leave you all with this statistic one more time, which is that fewer than 10% of people who qualify for an implant actually receive one. So again, I hope that you have learned that a lot more people out there would probably qualify for an implant than you think. And so if you or somebody that you know are really having a hard time understanding speech or communicating with those around you, and you wear hearing aids, it may be time to wonder if a cochlear implant could help you. And that is all I have. So I will turn it over to Dr. Perez.
Well, thank you so much, Dr. Glasstetter. That is a great discussion, and we're just both really thrilled to be here and appreciate all of you joining us for this kind of lunch time chat. And we're really excited about our cochlear implant program and just about the progress that cochlear implants in general have made over the past several decades. So it's really just incredible. I still go to meetings with some of the people who were first implanting this, and they were thought of as crazy to think you could stick a wire in the inner ear and that somebody is going to end up understanding speech. But it's really miraculous that we have this technology, and it's really part of how I ended up in this field because it's a wonderful gift to be able to restore somebody's ability to understand speech, to communicate with others. So it really is an incredible part of our jobs. We love to do this, and we love to see the success. And it's really our goal to broaden access to cochlear implants and to keep pushing the envelope on how we can achieve greater success for more patients to live the lives they want to. So why hearing loss matters. Over 430 million people worldwide have disabling hearing loss. So it's a huge and growing percentage of the population that is really affected by this disease that changes your quality of life. And it affects your communication with others, but your ability to function independently in the world. It's also been linked to your mental health and your cognitive health as well, in that if you can't hear and communicate and interact with those around you and really understand others, you are at risk for further cognitive decline. And it's one of the most prevalent preventable sources of advancing dementia. So it's really important that we think about this and address this to be able to do everything we can to keep people healthy and functioning at a high level. We know that hearing loss is linked to social isolation, to depression, and like I mentioned, cognitive decline. So it really can affect every aspect of your life and have a huge impact. So Dr. Glasstetter reviewed this, but a cochlear implant is done with a surgery. So I'm a cochlear implant surgeon, and along with me are my partners here, Peter Santamaria and Greg Basura. So all three of us perform cochlear implant surgery and work with Dr. Glasstetter and her team of cochlear implant audiologists. So it's a specialized type of audiology, and it's one of the most common surgeries that we perform here in our division of ear surgery. It's like Dr. Glasser described, we're really bypassing the part of the inner ear that is not working well. And it's those tiny little cells we call hair cells that are in charge of taking the fluid movements of the inner ear that are transmitting vibrations from the eardrum in the outer world to turn those into fine-tuned electrical signals. And those are the cells that die and stop functioning and cause hearing loss. So we're bypassing the part of the inner ear that doesn't work. And miraculously, most of the time, when that part of the inner ear is not working, the hearing nerve itself is still functioning well. So if you can bypass that short circuit, you can stimulate the hearing nerve and send electrical signals to the hearing nerve and on up to the central auditory nervous system. So it's converting sound into electrical signals that directly stimulate the auditory nerve, the hearing. And so a hearing aid is amplifying sound, where a cochlear implant is sending that sound directly to the auditory nerve via an electronic signal. The hearing aid needs your inner ear to still work well, so you're just turning up the loudness of the sounds around you. But a cochlear implant can work even when that part of the inner ear is not functioning. And a hearing aid can help for mild to moderate loss. When there's severe to profound loss, and you get to the point where even a hearing aid at the best programming and optimized settings, you're really struggling to understand speech, that's when we think about the option of a cochlear implant. So we talked about this idea that traditionally you really had to be deaf in both ears to qualify for cochlear implant. So that's who initially was receiving this technology. And as we've had more and more experience with patients who receive a cochlear implant and do well, that's what's led to this broadened criteria of who do we think is really going to be successful and benefit from a cochlear implant. Prior it was limited benefit from hearing aids, even with maximum amplification. But we talked about now there's really an expanded candidacy. So you can still have some of your natural hearing and be a candidate for a cochlear implant today. Especially the residual low frequency hearing is a common type of hearing loss where people really tend to lose the higher pitches and higher frequencies to a greater degree than lower pitches. So if you have hearing loss, you may notice that some of those really high pitched sounds like birds chirping or maybe a young child's voice can be more difficult to discern than a lower pitched sound that you still have some of your natural hearing. But more importantly, just like Dr. Glasstetter said, it's not just hearing sound, it's really understanding speech. And so that's where we've come to realize that there are people who still have some of the residual hearing, but the ability to understand speech is reduced to such a degree that we think with a cochlear implant, they really can perform at a higher level. And then really exciting that now single-sided deafness has been approved by the FDA in 2019 to be treated with a cochlear implant. Those are patients who before we were basically giving up on that ear, saying we're not going to be able to stimulate that deaf ear and you're just going to rely on one ear. Now we're able to bring back the benefits of binaural hearing or hearing with two ears, localizing sounds, being able to parse out what you really want to hear when there's background noise and focusing on what is it that you really want to hear when there's competing acoustic targets. So it's really exciting that this criteria are expanded and more people are able to benefit from a cochlear implant. So how do we determine who's a candidate? It's really an essential evaluation that happens by multiple parts of this team. And so there's a big component from our audiology colleagues who are testing the hearing with the basic pure tone threshold, so the beeps you may have heard, and the list of words that are read in a sound booth for a typical hearing test that's done for various reasons. But it's really that speech recognition testing. So the testing is much more in depth than just a standard hearing test, and involves a lot of sentences that are read to you that you have to repeat back. They're read on a recorded voice by a man's voice, a woman's voice. They're done in quiet environments and then with background noise. So we're trying to create more of a test of what are the real world challenges of hearing. So it's not just sitting in a box with beeps, but really that speech understanding. And it helps us identify, somebody may be able to hear that somebody's talking to them or hear a variety of pitches at low, middle, and high frequencies, but they're missing the understanding. And that's where we think that the cochlear implant can come in. And then it's essential that we really interrogate are people fit with good hearing aids that are programmed for their level of hearing loss, because it's also the case that we encounter patients who are looking into this option of cochlear implant, and we realize they haven't been set up with the optimal hearing aid option, and that there are options that can still help them function at a high level with hearing aids and not need a cochlear implant at that time. And then me as a surgeon, it's important that I make an assessment of the patient's overall health, their ability to undergo general anesthesia. We will obtain a CT scan, a CAT scan that looks at the inner ear anatomy and helps us make a plan for surgery and the actual way that we approach surgery. Interestingly, I only treat adults, but on the pediatric side, there are a variety of causes of hearing loss that can cause differences in the anatomy of the inner ear. And so that's something that's also parsed out with some of those X-ray CT scans that help us identify different anatomy. And even that is expanded, where we would previously say this inner ear looks too abnormal, it probably won't receive a cochlear implant and function well. And more as we've pushed the envelope on who could potentially benefit from a cochlear implant, we see that even some ears that in the past people would have said would not be receptive to a cochlear implant, those patients can still do really well. So we talked about the broadened criteria. So poor speech recognition with scores that are less than or equal to 60% while wearing hearing aids, and moderate to profound high frequency loss. You can still have a lot of those lower pitches preserved. And really, it's wonderful to see that the coverage of what is going to be provided and paid for to have a cochlear implant is expanding to encompass the fact that more and more people are benefiting at levels of hearing loss that we wouldn't have traditionally thought needed a cochlear implant yet. And what do we count as success for cochlear implantation? What we really want to see is a dramatic improvement in speech understanding. And fortunately, that's the vast majority of the time. That's what we see, is a significant improvement in your ability to understand speech compared to just wearing hearing aids alone. So it's really that clarity issue. And with that, our goal is to see a better quality of life, social engagement. You're doing the things you wanted to do. You're able to talk to your family and friends and engage with them in a way that your hearing loss was a limitation before. And then cognitive health. By understanding and engaging and remaining socially active, you're also helping the health of your brain and your cognition. And it's exciting to say that this is a safe outpatient procedure, and that really is overall low risk procedure with a low chance of complications. We see benefits at all ages. So it's most common that we're doing the surgery in older adults who previously had good hearing in their younger age, and with time see diminishing hearing. And so being able to improve their communication and really reduce that risk of cognitive decline is essential. But we also see many patients who develop early onset hearing loss, or who are exposed to louder noises than previous generations, and to be able to restore their ability to function, to do their jobs, to work, and be engaged socially is a huge benefit. We've said this a number of times, but part of why we're always trying to educate and help patients know what is accessible is that of the people who are candidates for cochlear implant and for whom we think would benefit quite a bit, only 5 to 10% of those patients actually have received a cochlear implant. And we know that there's a lack of awareness of who is going to be an appropriate candidate. We know that there are delays in referrals, and we know that there are misconceptions about surgery outcomes. So trying to broaden people's access to information, to know what their options are, to help them figure out if this could be a good option for them. So how do we overcome those barriers? We are always trying to educate the front line of healthcare providers, of primary care, and even within the audiology world, not everyone is a specialist in cochlear implant like Dr. Glasstetter, making sure that audiologists who are on the front lines know when it's a reasonable time to think about considering this option, considering that more in-depth testing to see, are hearing aids not going to cut it anymore, and could somebody actually benefit more from a cochlear implant? And then letting patients know they really could consider this option. And not delaying that referral for evaluation, but it's our pleasure to talk to patients about this and help them get that information. And it's common for us to see patients who ultimately are not quite at the point where they would consider a cochlear implant, and that's great because they still have the ability to benefit from hearing aids, and they know what their hearing health is at that time point, and have something to compare down the line. So they have more information about what their options going forward could be. And we always try to have that be done in a timely fashion. So what are the continued advancements in cochlear implant? A big issue that is discussed at all our research meetings and all our national conferences is this idea of hearing preservation. So when that tiny wire electrode is introduced to the cochlea, and especially in a cochlea where an inner ear where there's still some residual natural hearing, it's really our goal to limit anything that could cause the reduction of that residual hearing loss, residual hearing. Finding ways that we can optimize hearing preservation. One of the ways that we're able to do that now is with technology that lets us monitor the function of the inner ear during the surgery. So while we're placing that electrode, we can get a live feedback on the health of the inner ear. There are companies looking at robotic assistants, including one that has one of their headquarters in Pittsburgh, looking at robotic assistants to minimize any micro traumas or irritation of the inner ear caused by human tremor at the time of surgery. And then telehealth applications. You know, it's intensive follow-up with audiology. It's a lot of work, and expanding access, especially to patients who might not live close geographically to a center for cochlear implants, to be able to expand, especially some of the follow-up with programming and learning to use the device with audiology is also helping us expand who has access to a cochlear implant. And then just as there are clearly advancements to happen with hearing aids, the same with the external processors of how do we make these devices that are meant to capture the sound around us really capture the sounds we want to hear. So you're not hearing the dishes clinking at the table next to you, but at the busy restaurant, but you're hearing the person in front of you. So there's continued advancement in that software and that technology that we hope can further the benefit of people with cochlear implants. So, you know, cochlear implants restore meaningful hearing aid when hearing aids are not enough. And more people are eligible who traditionally we would have said, don't go for a cochlear implant yet. More of those people we found can truly benefit more from a cochlear implant. And so more people are candidates. It's a safe surgery, it has proven success, and it's really can be life-changing when it comes to your hearing. And we like to emphasize, you know, timely referral for us to evaluate and see, you know, could you be a candidate for that? So thank you. It's been a pleasure to chat with you all, and thanks to Dr. Glasstetter for lending her expertise and to the foundation for letting us share this lunch hour with you all.
Well, thank you very much, both of you, Dr. Perez, Dr. Glasstetter. Man, we have a lot of information out now, just and so much has changed when you think about cochlear implants over 40 years that this has been happening, and of course we know so many people with them, and I imagine that the technology today is going to be helping people in different ways. I have a question myself as we get into the questions. We have several submitted, and this is the time, folks. If anybody wants to submit a question, we will only use the hour that we have available, but we can answer questions, offline as well to anybody that has any. So please submit them. But as you talk about using natural hearing as well as the cochlear implant digital hearing, is it difficult for patients? Now, I've heard what the digital sound is like when someone is receiving the input from a cochlear implant, and it's not like our normal hearing. It sounds very digital and maybe a little bit hard to decipher if you weren't listening, used to it. Is it a challenge when there's a mix of both the natural hearing and the digital hearing? Does it confuse the patients?
Yeah, that's a really common question. Dr. Glasser, do you want to answer?
Sure. At first, it can take time. Yeah, absolutely, to integrate the two sounds, but eventually it really becomes a significant benefit. So for the brain to have access to some natural hearing, whether that's with one cochlear implant and one hearing aid, or whether that's with how I talked about the electroacoustic stimulation with some hearing and some cochlear implantation, it can really help make the device sound more natural and actually take away from that robotic sound quality. And having access to those low frequencies with acoustic hearing can also help with things like telling where sound is coming from and hearing in background noise. So it can be challenging at first, but ultimately it is definitely a benefit.
And the statistic is just alarming that only 10% of the people who are candidates for a cochlear implant are actually receiving them. And you said it, both of you, and I know Dr. Perez, you mentioned how devastating it is for us not to hear in terms of our overall health, cognitively and in many other ways. And is it as much that the criteria also has changed because now more people are candidates, as it is also that maybe there's just a general lack of awareness or understanding about how much people need to address hearing loss as a society?
Yeah, I think it's definitely helped that we see more and more people who understand the overall ramifications of hearing loss. And we love to see when families are there with the patient saying, we all know this is a problem and it's really changing their overall health and their ability to keep on doing the things they want to do. So I think that broadening awareness has really helped, but we still have room to go, still more to help people know that can have a huge impact for sure.
So I have some questions here about the surgery itself. So has the cochlear implant surgery gotten shorter over time? It used to take 4 hours, say like 20 years ago. Is it still that kind of lengthy, involved procedure?
That's close to what I would say most cochlear implant surgery is. Maybe more like 3 hours, but pretty similar mechanics. And really, we're doing the surgery in a very similar way, the same instruments. So not a lot has changed about the mechanics of the surgery, and truthfully, even the electrodes that are being placed. A lot of the hardware and the mechanics of the surgery itself are pretty similar to what they were 20 years ago.
Now, is it better for people to get the implant at a younger age in terms of how successful they'll be in terms of maximizing their ability to communicate and hear sounds over the period of their life if they start losing their hearing at a young age?
Yeah, there are data that suggests that if you are implanted, earlier on, your outcomes can be better. And part of that is because if your hearing loss goes untreated or, inappropriately treated with maybe not enough sound coming from your hearing aids, um, again, those auditory nerve fibers, they are use it or lose it. So if they're not used, they kind of get rerouted, or they just stop functioning altogether. So then when we try to stimulate them with the cochlear implant, all of a sudden it's just not going to happen. And then I would also argue, if you are going to hear better with an implant, why not do it sooner, right? That's going to be more years of your life when you are more in your prime, in your golden years, to hear those around you, rather than waiting until maybe you're a little older and don't have as many activities, I would say.
Right. Okay. When does someone after they've received their implant, when is it actually turned on? How long after surgery is the implant turned on?
It's a good question. We used to do 4 weeks after to let all the swelling and go down and the healing, happen. Now we're doing about 2 weeks, but there are some centers doing same day activation.
Wow.
So that is, I would say, another advancement that's happening and progress that's happening in the field. Some centers are doing same day, evaluation, surgery, and activation. So it just, because, Dr. Perez mentioned, a lot of people live pretty far away from these cochlear implant centers. So we're a very specialized field, and it can be really hard for people to get to our clinic. So, maybe someday we'll do a same day, one-stop shop, but typically about 2 weeks.
Okay. We're just about out of time, but I'm going to ask 2 more questions here that are on here. Can you talk a little bit more about the robots? Like you're talking about a surgical robot, right, Dr. Perez?
Yeah. So one thought with a really crucial part of the surgery is when you're actually placing that tiny wire electrode. So all the surgery is done in a space this big. So we're under the microscope, very fine, delicate movements. We're making sure we don't paralyze your face or make you dizzy. There are a lot of high value real estate around the inner ear. But when we open the inner ear, that tiny wire electrode is slowly advanced. And our goal is to do that in a way that causes as little trauma or irritation or inflammation as possible, with the thought that if you are especially rough or that electrode were kind of bouncing around and hitting the wall or the middle of the cochlea, you could cause damage to those structures. So you could further damage the inner ear. And if we can protect the health of the inner ear, whatever is left, we know that that's better for your outcome overall. So there are surgical devices that are designed to cause very slow, steady insertion of that electrode, so they can assist where the surgeon might have a tremor when you're magnified 20 times, and you can see those tiny micro movements, to try to reduce that and create a very slow, steady insertion of the electrode. So that's an active area of research and development, and application is being used in people.
Very interesting. Last question. Are bilateral implants usually needed? Is that more common? And they do those in the same day if they're going to do a bilateral implant?
Usually not in the same day. For adults, usually you would do one ear at a time. And a thought process for that is you want to make sure somebody is successful and really benefiting from their cochlear implant, and not put their other ear at risk of having loss of the residual acoustic hearing, not being able to use a hearing aid in either ear during that early time after surgery. But we really like to see people be successful and happy with one side before going to the other side. And I have many patients who do so well with one side, they say, I don't want a second one. I'm doing great. Like, I'm going to go live my life. And there are also benefits to continuing with a hearing aid and your natural acoustic hearing in one ear and a cochlear implant in the other. So there are reasons to say don't go for a second cochlear implant, although many patients can benefit from 2 and do choose that option.
Wow. Overall, really, really interesting presentations and wonderful information to share. Take-home messages, please tell people if they're struggling with their hearing to get their hearing tested. We really, really need and benefit from hearing as best we can. And whether it's going to be from a hearing aid or, as we see, many people need cochlear implants, it really improves not only your quality of life, but your overall health, your cognitive health, and it, and your spouse will be happier as well. So thank you for everything. And just a reminder to everybody that this is recorded, so you'll receive the recording in a few days, and you'll get that, and you can share that. And we make all of this possible, all of the work that goes on, all the research that goes on, and all the things that we do possible through the Eye and Ear Foundation, through your support. So thank you if you have been a donor, and let us know if you'd like to know more information about how to support the Eye and Ear Foundation. Have a wonderful day. Have a wonderful weekend, everybody.